Hi guys, we'll be starting in just a minute. I'll just give it a few more minutes for people to join. So I think you guys should be able to see my screen. And we'll make a start. Yeah, that's fine. So this is part of the Mind the Bleep UKMLA Endocrinology series. This is the first session. We'll be covering diabetes. So this will be covering kind of the pathophysiology, presentation, how you diagnose diabetes, differences between type 1 and type 2 diabetes, and complications, etc. We'll be doing another session on like diabetes and endocrinology emergencies, so things like DKA and HHS and things like that. And some other topics will be covered in another session. But we'll start with the pathophysiology. So starting with type 1 diabetes. So this is kind of a absolute insulin deficiency. So it's kind of defined as a total lack of endogenous insulin production. Endogenous meaning kind of what the body produces or what the body's able to produce. It's autoimmune mediated. So basically you have destruction of the beta cells in the pancreas. And then this is also marked by subclinical inflammatory infiltration of the islets, also known as insulitis. So that inflammation kind of drives the destruction of the pancreatic beta cells, and that leads to them not being able to release insulin. There is genetic susceptibility, so there are strong links to human leukocyte antigen, so HLA, particularly DR3, DQ2, and DR4, DQ8. And then there's just a diagram there kind of showing how the T cell mediated beta cell annihilation comes about. And then if we compare that to type 2 diabetes in terms of pathophysiology, it's kind of a mix of insulin resistance and impaired insulin secretion. So insulin resistance meaning the sensitivity is reduced in major metabolic tissues. So tissues such as skeletal muscle, adipose tissue, and the liver can all become insulin resistant. So you get impaired glucose uptakes in terms of skeletal muscle. In terms of the liver, there's failure to suppress glucose production and adipose tissue as well. And then with type 2 diabetes, you get a compensatory hyperinsulinemia. So because the blood sugars are high, the beta cells kind of adapt initially by increasing their mass and secretion to overcome the resistance and maintain kind of normal glucose levels. Obviously, this happens over time, gradually, and then eventually you get to a point where type 2 diabetes actually develops and manifests. And this is kind of when you can see the beta cells can no longer keep up with the elevated demand of releasing insulin. This is just a little table describing kind of the key differences between type 1 diabetes and type 2 diabetes in terms of pathophysiology. So type 1, as we said, absolute insulin deficiency, whereas type 2 is kind of a relative insulin deficiency and mixed with insulin resistance. In terms of the beta cell function, with type 1, you have kind of near total destruction of the beta cells, whereas, as I mentioned, in type 2, it's kind of a gradual decline because they're overworking and kind of compensating for the high blood sugars. And again, other pathophysiological drivers and other things there. And then we'll move on to the clinical presentation. So kind of the classical presentation of type 1 diabetes, you get symptoms such as polyuria, polydipsia, so increased urination, increased thirst. You may also see weight loss and fatigue. Typical age of onset is less than 40, so you kind of see it, you may typically see it in kind of teenage age years, so kind of like between 12 to 18 or so for the first presentation. But we'll say typical age of onset can be less than 40, as you can see it develop in kind of older people as well. Up to 25% of type 1 diabetics present for the first time in DKA. So it's not rare to see kind of young patients coming in with nausea, vomiting, dehydration, abdominal pain. And that's kind of like the first sign of their type 1 diabetes manifesting. And then you also have Kussmaul's breathing or respirations, which are kind of deep, rapid respirations that you'd see in DKA. We'll cover DKA in another topic, in another session, as part of the endocrinology series. And then when we compare that to type 2 diabetes, so many patients with type 2 diabetes can be asymptomatic and is kind of picked up as an incidental finding. Some signs that you may see are acanthosis nigricans, which I've put a little picture there. It's essentially velvety, hyperpigmented skin, kind of typically seen in the folds. So kind of the neck is a common area. You can also see it in the axilla as well. And this is a sign of severe insulin resistance. Other signs that you may get with type 2 diabetes, fatigue, blurred vision, more frequent infections, so candidiasis and UTIs. And again, you may see the polyuria and polydipsia as a result of kind of quite high blood glucose levels. HHS, so patients may present acutely in HHS, typically older patients who are kind of profoundly dehydrated and as a result extremely hyperglycemic as well. Differentiating this with DKA, one thing would be you don't get significant ketosis. But again, HHS is another thing that we'll cover in another session in more detail. And then with type 2 diabetes, comorbidities is a huge part. So you may see hypertension, dyslipidemia, macrovascular disease, and obesity as well as quite closely linked with type 2 diabetes. And then again, in the kind of table showing the quick differences between kind of classical presentations between type 1 and type 2 diabetes. And then we'll go on to diagnosing diabetes. So again, we'll start with type 1 diabetes. Typically a clinical diagnosis. There are some tests that you do to kind of make a formal diagnosis of type 1. So in children and adults, type 1 is based on kind of symptoms and hypoglycemia. So there are specific high-risk features, so polyuria, polydipsia, rapid weight loss. As we said before, they may present acutely in DKA. They may also have a family history or personal history of autoimmune conditions. And again, typically you have a picture in your head, the patient will kind of, not every patient fits the criteria exactly, but typically age less than 40, as we'll say, and kind of a lower BMI in comparison to type 2 diabetes. So there are, as I mentioned before, there are other tests that you can do when classification is uncertain. So sometimes a patient may present and you know they have diabetes, but you're not sure whether it's specifically type 1 diabetes or another type. So islet autoantibodies, so glutamic acid decarboxylase, so GAD65. There are other ones, islet autoantigen, zinc transporter antibodies. These are all islet autoantibodies. And essentially, these are tests that you can do when classification is uncertain. With these tests, they have their lowest false negative at the time of diagnosis. So the best time for the islet autoantibodies to test for them is kind of when the patient first presents. I will say carrying out kind of 2 of these tests, so 2 different diabetes-specific autoantibodies is recommended as well to reduce the false negative rate. So again, you may get false negative findings from the tests. And then C-peptide levels. So C-peptide is basically a byproduct of insulin processing, and then it serves as kind of a proxy for endogenous insulin production. So essentially, C-peptide, a byproduct of the body producing insulin. So if we think of the pathophysiology of type 1 diabetes, C-peptide levels will be low because their pancreas isn't producing much insulin, so therefore there's not much C-peptide. Whereas if you compare this in type 2 diabetes, the C-peptide levels will be normal or high because the body, as we said, is kind of producing a lot of insulin to try and counteract those high glucose levels. There are other tests as well. So kind of monogenic diabetes, there's genetic testing that can be done if kind of you're suspecting monogenic forms of diabetes, such as MODY, so maturity onset diabetes of the young, or sometimes neonatal diabetes as well. And then there are new kind of pathways which are kind of aiming to identify children that are at risk of type 1 diabetes through autoantibody screening. And this basically allows for prevention of patients coming in for the first time with DKA. So kind of identifying these patients earlier before they present acutely to A&E. And then the diagnostic criteria for type 2 diabetes. So I've split this up into asymptomatic patients and symptomatic patients. So as I said before, it's common for type 2 diabetes to be completely asymptomatic and detected only through routine screening or incidental findings. And then with asymptomatic patients, diagnosis must not be on the basis of just one single test. You need a repeat confirmatory test on a different day to establish the diagnosis. And with the repeat test should ideally be the same as the first. So if you test HbA1c the first time, you want to ideally test HbA1c again, rather than doing HbA1c and the fasting plasma glucose, for example. And then if they're both kind of above the diagnostic threshold, then this confirms the diagnosis. So again, there's a small table here just highlighting the difference. So fasting plasma glucose levels, you're looking at a level above 7 millimoles per liter. So this kind of is the threshold for kind of diagnosing or initially diagnosing type 2 diabetes in the asymptomatic patient. For the oral glucose tolerance test, you give the patient a high glucose drink with 75 grams of glucose. And you test their blood sugars 2 hours later. And if this is above 11.1 millimoles per liter, then that's diagnostic for type 2 diabetes. And then again, HbA1c, a figure over 48 millimoles per mole or 6.5% is used to diagnose diabetes. And then we go to symptomatic patients. So they'll come in with the symptoms that we've mentioned before. So hyperglycemia, polyuria, polydipsia. You can do random plasma glucose. So if that is above 11.1 millimoles per liter, this is diagnostic of type 2 or diabetes, I should say. And then there are other confirmatory tests you can do. So the fasting plasma glucose, the glucose tolerance test, HbA1c, which I mentioned before. If the person's symptomatic, then a single abnormal HbA1c or fasting plasma glucose level can be used. But you may still want to test again. Just it's a sensible thing to do to confirm the diagnosis. I will point out that HbA1c is good, but there are kind of limitations as to when you can use HbA1c to diagnose diabetes. So it shouldn't really be used in children and young people under the age of 18, pregnant women, people who are at risk of diabetes, but they're acutely ill, people taking medications that can cause increased blood sugar levels. So people who are on kind of long-term steroid treatment, because steroids can shoot up your blood sugar levels. And people with kind of end-stage renal disease as well. You shouldn't really be using HbA1c. You can use another modality to confirm the diagnosis. And then with HbA1c, it can be, the figure that you get can be affected by kind of blood conditions. So people with abnormal red blood cell turnover or abnormal hemoglobin types. So, for example, people with sickle cell or severe anemia, recent blood transfusions, or anything that will alter the kind of life cycle of the red blood cells. So if they've recently had their spleen removed, for example, and this is because kind of the HbA1c test is kind of, it relies upon seeing how kind of the blood sugar for the past 3 months, for example. So if something's affecting the turnover of cells, for example, that will kind of skew the HbA1c either up or down depending on the condition that the patient has. So just bear that in mind. And then we have things such as prediabetes, impaired fasting glucose, or impaired glucose tolerance. So there are kind of an estimated 5 million people or so at risk of type 2 diabetes in England. Prediabetes or borderline diabetes is a term that's used to signify that someone is at risk of developing type 2 diabetes. Impaired glucose tolerance is a stronger predictor of cardiovascular disease than impaired fasting glucose, and it kind of has a progression rate annually of around 5 to 10%. So about 5 to 10% of people with impaired glucose tolerance will kind of annually progress to developing type 2 diabetes. In terms of the figures for the different types of non-diabetic hypoglycemia, you can see pre-diabetes, a HbA1c of between 42 to 47. So below the threshold for type 2 diabetes, which is 48, but above 41 essentially. So you can think of them as being in like the danger zone. Impaired fasting glucose kind of tells you in the name. The fasting glucose is over 6.1, but less than 7. So not quite enough to diagnose type 2 diabetes at 7 millimoles that you'd use, but above 6.1. Impaired glucose tolerance is defined as fasting glucose less than 7, and the oral glucose tolerance test where we give them the 75 grams of glucose and measure 2 hours later, greater than or equal to 7.8, but less than 11.1. So again, less than the 11.1 figure to formally diagnose diabetes, but above 7.8. And then we go on to management. So management of type 1 diabetes, you have, we don't cover this too much in depth, but you kind of have different regimes that you can use. So you have the basal bolus regime. So this is kind of the gold standard because it's most kind of physiological. So in terms of how the actual pancreas releases insulin and manages blood sugar, the basal bolus kind of mimics this the best. So you have your basal insulin, so long-acting insulin, which will provide a steady background of insulin. And then you have the bolus. So boluses are rapid-acting analogs. The patients will take them kind of 15 minutes or kind of sooner before food. And then this manages the rise in blood sugar that is a result of the patient eating at that mealtime. And then you also have insulin pump therapy. So it uses a small device to deliver continuous basal insulin with, again, boluses given at mealtimes. And this is indicated for children where kind of you wouldn't really expect a child to manage or tolerate multiple injections a day. And also for other people who multiple injections may be impractical. So if they're pregnant or if they're a type 1 diabetic and they're planning pregnancy, we can get them onto an insulin pump sooner. Yeah. And then we go into type 2 management. So we as you'll know, there are multiple different medications that you can use for managing type 2 diabetes. Some are still in fashion, some are out of fashion, some are kind of newer medications, and we'll kind of go through a few of these now. So you have metformin, which is a biguanide, and how it works is essentially it decreases hepatic gluconeogenesis, so new kind of glucose production from the liver. It decreases that, and then also increases peripheral insulin sensitivity. So as I mentioned before, it will increase how much the kind of skeletal muscle tissues can take up glucose and um, reduce blood sugar levels essentially. Contraindications to be aware of. So EGFR less than 30. Side effects most commonly with metformin, gastrointestinal upset. So if a patient started on metformin, they're not tolerating it, they're complaining of stomach pain, nausea, etc. You can then offer modified release metformin, and then see if they tolerate this a bit better. Other side effects include lactic acidosis, vitamin B12 as well. Cautions, so may cause lactic acidosis if taken while there's ongoing tissue hypoxia. So essentially, in situations where there's a recent MI or sepsis or AKI, the buildup of metformin can cause a lactic acidosis. So you want to be careful to start or continue metformin when patients in hospital with any of these kind of conditions. Sick day rules, you want to again suspend metformin during episodes of dehydration or kind of sometimes acute illness depending on the illness, so sepsis and things like that. Just an extra note, metformin is not one of the oral anti-hyperglycemic medications that cause hypoglycemia or weight gain. And then we have sulfonylureas, so most commonly glycoside. Essentially, these bind to the SIR1 receptor on pancreatic beta cells. This closes the potassium channels, and then this kind of causes cellular depolarization, leading to the secretion of insulin, which is independent of the current blood sugar levels. So obviously, insulin is typically secreted when blood sugar levels are high. Sulfonylureas work and boost this secretion of insulin independent of the blood sugar level. So you can see why this would be dangerous or potentially cause hypoglycemia. So that's the primary concern. The risk is highest with the elderly or patients with renal impairment, and also those with kind of erratic or irregular meal patterns, because they'll have their sulfonylureas when their blood sugars are already low, and then the glycoside will drive the blood sugars even lower because of the release of insulin. Side effects of these include hypoglycemia, as we mentioned. Glycoside does cause weight gain, and it can cause beta cell exhaustion. So again, because the pancreas is working overtime, it can lead to that beta cell exhaustion that I mentioned earlier quicker. Some considerations to be made, patients with CKD. So essentially in patients with advanced kidney disease, you can use other sulfonylureas. So instead of glycoside, you may use glipizide because its metabolites have less hypoglycemic activity, if that makes sense. And then we'll go on to the SGLT2 inhibitors. So these are your flozins, so dapagliflozin, empagliflozin, canagliflozin. These inhibit glucose reabsorption at the proximal convoluted tubule of the kidney, and this leads to the excretion of roughly 60 to 80 grams of glucose per day via the urine. So essentially, the patients taking SGLT2 inhibitors lose or pass urine through their pass glucose through their urine, lowering blood sugar levels. In terms of benefits, you have cardiovascular protection. So these significantly reduce the risk of heart failure, hospitalizations, cardiovascular death, and MACE, so major adverse cardiac events, basically, such as heart attacks or strokes. They offer renal protection as well, so they're highly effective at reducing albumin, urea, and slowing the progression of CKD toward end-stage renal failure. Metabolic effects. So these agents, SGLT2 inhibitors, typically provide a modest weight loss of around 2 to 3 kilos and don't usually cause hypoglycemia when used as monotherapy. And then a big kind of thing to think about with SGLT2 inhibitors is the kind of adverse effect of euglycemic DKA. And this is ketoacidosis, which presents with normal or near normal blood glucose levels. So again, similar symptoms as normal DKA, abdominal pain, nausea, vomiting. The reason it's euglycemic is because the patients are passing the glucose through their urine. So the blood sugar levels may be normal, but they're still in ketoacidosis essentially. And just a note, SGLT2 inhibitors, so dapagliflozin, empagliflozin, canagliflozin, are all temporarily stopped during acute illness, dehydration, or major surgery, and this is to prevent DKA. And they're also stopped in patients who have had an episode of euglycemic DKA. So patients on one of the SGLT2 inhibitors, they have an episode of euglycemic DKA. You'd want to stop the kind of causative agent, the dapagliflozin or SGLT2 inhibitors, and switch to something else. And then we have GLP-1 receptor agonists, so things such as semaglutide, liraglutide, exenatide, dulaglutide. These essentially are glucagon-like peptides. They mimic GLP-1. This stimulates glucose-dependent insulin secretion, suppresses glucagon, and delays gastric emptying. Benefits, weight loss. So they produce intermediate to very high weight loss, often for between 4 to 6 kilos. So they're well suited for patients who are obese or overweight. They again offer cardiovascular protection and renal protection, just like the SGLT2 inhibitors. They carry a lower risk of hypoglycemia when used as monotherapy because, unlike sulfonylureas, their action is dependent on the blood glucose levels. So with GLP-1s, you get the insulin secretion, but it's dependent on the blood glucose levels, so less risk of hypoglycemia. Sulfonylureas independent of blood glucose levels, so you have that risk of hypoglycemia. Contraindications, family or personal history of medullary thyroid cancer or MEN2. And adverse effects with GLP-1s, you're looking at pancreatitis and again, GI disturbances. And then tirzepatide or Mounjaro. This is a dual glucose dependent insulinotropic polypeptide. So it's kind of a GIP and GLP-1 receptor agonist. It binds to both receptors to increase sensitivity, insulin sensitivity and secretion, suppress glucagon, and decelerate gastric emptying. So kind of 2-in-1. Benefits, you get superior glycemic control. So it's demonstrated a greater effect on reducing blood glucose levels compared to the GLP-1, just the GLP-1 receptor agonist that we spoke about before. It's kind of it's the best kind of for weight loss outcomes. So it's the most effective medication for body weight reduction in adults with type 2 diabetes, with reductions of roughly 8.6 or so kilos. And then some patients achieve weight loss from about 15 to 20% of body weight. There is some data emerging from studies showing that it may provide renal benefits by slowing down the decline of GFR, essentially, and reducing the albumin to creatinine ratio as well. The most frequent adverse effects, again, GI disturbance, nausea, vomiting, diarrhea, are common initially, but typically resolve over time by titrating down, by titrating the dose slowly rather than rapidly. Because of the way it works and the delayed gastric emptying, there is a risk of pulmonary aspiration during anesthesia or deep sedations. So patients who are going for surgery and things, obviously because there's delayed gastric emptying, the kind of normal times for how quickly the patient can eat may be slightly different if they're taking one of the, well, tirzepatide or Mounjaro, otherwise known. And then this is just the kind of summary of kind of the newer kind of guidance for type 2 diabetes. So it's kind of a weird stage where there are draft guidelines from August 2025, and I think the full guidance is meant to be released in February 2026, so next month. So there have been some changes into the kind of treatment options or treatment pathways for patients with type 2 diabetes. So it kind of goes from a one size fits all. So essentially everybody starts on the same drugs to it's now stratified to kind of the characteristics the patient has. So if they have no comorbidities, if they've got CKD, heart failure, etc., you'll be starting them on different kind of medications. So kind of other key takeaways from this: adults with cardiovascular disease should be offered triple therapy, including a GLP-1 agonist, because of the benefits that we've mentioned before. Another takeaway is adults with early onset type 2 diabetes, so basically diagnosed with type 2 diabetes before the age of 40, are offered dual therapy before a GLP-1 receptor agonist is considered. And then I'd say look at this in your own time. Obviously, it's a lot to kind of go through and a lot of different patient categories to look at. But again, you can see, so for example, if we look at obesity, where you offer metformin and an SGLT2 inhibitor, and if you compare that to kind of frail patients where you have to kind of think of starting them on medication slowly based on their risk factors and things like that. So it's not just as it was previously, where you give everyone kind of the same treatment and follow it in a stepwise manner, depending on whether they're reaching their glycemic targets or not. And then we go on to complications and screening. So kind of a quick overview: complications occur in diabetes due to years of insulin resistance, low-grade inflammation, and atherogenesis, basically. So you have macrovascular, microvascular, diabetic foot disease, and systemic complications, which we'll go through. So atherosclerotic cardiovascular disease. So patients who are diagnosed with type 2 diabetes before the age of 40 face a very high lifetime risk of cardiovascular and renal complications. This is because they're living longer than they would have otherwise with type 2 diabetes, and as a result, their risk factors are higher. So patients are at risk of their 10-year risk of cardiovascular disease, or basically their Q-risk score is over 10%. And obviously they have a greater lifetime risk if they're diabetic. And then assessment-wise, essentially you want to identify established conditions such as chronic heart failure or established atherosclerotic disease, and then this will alter the recommended treatment pathways. And then prevention, you can see the SGLT2 inhibitors and GLP-1 receptor agonists, which we spoke about before. These are used to reduce those MACE, so the adverse cardiovascular events in patients with diabetes. And then we have some other complications as well. Peripheral arterial disease. This is another form of atherosclerotic cardiovascular disease. Management for established PAD, metformin, SGLT2 inhibitors, and subcutaneous semaglutide, so GLP-1. PAD is closely linked with diabetic foot as well. It's a significant factor for patients developing diabetic foot disease, essentially. And just a quick caution, patients with active foot ulcers, you wouldn't start SGLT2 inhibitors. So essentially, SGLT2 inhibitors, thinking of two kind of patient groups you wouldn't start them in. As I mentioned, the patient who's already had euglycemic DKA because it's a known kind of cause or precipitant of euglycemic DKA, and then also patients with active foot ulcers. So it's typically not started because there's a theoretical risk of theoretical higher risk of lower limb amputation in patients taking SGLT2s. So there's just some caution there. And then you have diabetic retinopathy. So this is a chronic progressive complication resulting from hyperglycemia, hyperglycemic vascular damage, and neurodegenerative changes. It's the leading cause of vision loss and blindness in adults, and it's characterized by damage to the retinal vasculature. So you get microaneurysms, hemorrhages, neovascularization, and it's split into two different stages, essentially non-proliferative diabetic retinopathy first and proliferative diabetic retinopathy. So for non-proliferative, you have different stages, so mild, moderate, severe. I've put a diagram here showing kind of the image of the eye and what the kind of findings look like. So mild non-proliferative diabetic retinopathy, one or more microaneurysm. Moderate, you would see microaneurysms, blot hemorrhages, hard exudates, which you can see in the photo. And then severe, you start getting more of the same, and you also have venous bleeding in at least 2 quadrants. And then the cotton wool spots that you can see basically soft exudates, so they represent areas of retinal infarction. And yeah. And then you have proliferative diabetic retinopathy. So this is essentially when there's neovascularization, basically new vessel formation, and or vitreous or pre-retinal hemorrhage. Patient may complain of kind of floaters, a grayish elevation, so seeing gray. So when you see gray on I think there might be an image here, but essentially they may also present with retinal detachment, where you would see kind of the retina pulling away from the supporting layers, and it presents as a grayish elevation. Obviously, risks for this include vision loss and glaucoma. And then we'll go on to management. So you want to kind of manage the blood sugar levels and hypertension as well. And then this will kind of reduce the effects that it's having, the type 2 diabetes or type 1 diabetes is having on the eye. You want urgent ophthalmology review if you're suspecting proliferative retinopathy. Treatment options include pan-retinal photocoagulation. So this is using lasers to stabilize the retina and then reduce the rate of severe visual loss. Intravitreal VEGF. So this is basically anti-VEGF injections, and kind of common agents that you may hear of include aflibercept or ranibizumab. And then these are used in conjunction with the pan-retinal laser photocoagulation to reduce the vision loss. And then in more severe cases, you have surgical procedures. So if they're developing kind of vitreous hemorrhage that isn't clearing, then you may opt, or the ophthalmologist may opt for surgery. And then we have diabetic nephropathy. So this is persistent albuminuria and or a decline in the GFR in the context of long-standing diabetes. In terms of diagnosis, ACR or albumin creatinine ratio over 3 on at least 2 of 3 samples, all collected within a 3 to 6 month period. And then with diabetic nephropathy, you want to be thinking of blood pressure as well. So first line, well, the target would be 130/80. First line, you'd offer an ACE inhibitor or an ARB to all patients with a ACR over 3 with diabetes, regardless of whether they have hypertension or not. So you may see patients with diabetes who are taking an ACE inhibitor or an ARB, despite the fact that they don't have hypertension. And this is to kind of treat the diabetic nephropathy. Diabetic nephropathy is the leading cause of CKD and end-stage renal disease worldwide. Diabetic foot disease. So this is essentially disease of the foot in a patient with diabetes, and then they'll have symptoms such as peripheral neuropathy, peripheral artery disease. They may have ulcers, and they may have an infection. Kind of other complications could be a Charcot foot, which is kind of like a boat shape kind of foot, which and the foot kind of changes shape because of the pathophysiology. Gangrene, amputation, again, is another complication. As I mentioned before, peripheral arterial disease is the primary driver of infection and amputation risk. Screening-wise, you want to test for neuropathy, so you use a 10-gram monofilament for that. Ischemia, so you want to see whether the pulses are palpable. So dorsalis pedis, posterior tibial pulse. If they're not palpable, it indicates peripheral artery disease. And then obviously, as we said, there's a risk factor for diabetic foot disease. And all patients with diabetes should be screened at least annually for diabetic foot complications. And then you have kind of risk stratification. So low, medium, high, depending on what symptoms they have. Most ulcers result from repetitive trauma, so poorly fitting shoes on a structurally abnormal, insensate foot. So essentially, patients with the peripheral neuropathy can undergo repeat trauma, which they may not be aware about, and this leads to ulcer formation. And as I said before, untreated macrovascular disease, PAD, is the primary driver of infection and amputation risk. Do we have any questions? Okay, so I think that's everything for today. So it's kind of quick whistle-stop tour of diabetes, pathophysiology, treatment, kind of risk factors, and complications. We'll be doing, as part of the endocrinology series, we'll be doing another session covering firstly diabetic and endocrine emergencies, and then also other endocrinology topics as well. And yeah, thank you all for coming. And then there also should be a feedback in the stream, which you'll get access to